Now, as far as the treatment of cancer of the stomach is concerned, so just after the diagnosis and confirming the stage of the disease, now if the patient does not have any obstructive signs, that the patient is not vomiting and he is able to take food, soft diet at least properly, then initially itself we go ahead with chemotherapy initially to reduce the disease, that is called the neoadjuvant chemotherapy. So we give this chemotherapy to reduce the size of the tumor, mainly that of the primary and also of the lymph nodes, and then after say about 3 to 4 cycles we reassess the response of the neoadjuvant chemotherapy and then plan for the definitive surgery. Before doing the neoadjuvant chemotherapy, we go ahead with a diagnostic laparoscopy, or what we call the staging laparoscopy. This is basically a procedure under anesthesia, which is basically a short procedure. We put a scope into the abdominal cavity. After distending with the carbon dioxide gas, we see the inside of the abdomen. We look at the liver, the peritoneal surface. That means the inner layer of the abdominal cavity is called the peritoneal layer. That needs to be seen, and if there are multiple small nodules or the tumors are very small, they are picked up and sent for biopsy again. The reason is there is a limitation of a PET CT also. The PET CT in these cases of stomach cancer will not be able to tell you 100% about the extent of the disease. If the peritoneal nodules are less than 5 millimeters, then it will not be picked up on a PET CT. This is the very reason why we do a diagnostic or a staging laparoscopy before going ahead with chemotherapy. This gives us a proper idea as to whether to be very aggressive in the chemotherapy and further treatment plan, or do the chemotherapy only as a palliative method. That is one aspect. Second thing is that nowadays we are also seeing certain benefits from the HIPEC. HIPEC means hypothermic intraperitoneal chemotherapy. This chemotherapy, which is given into the peritoneal cavity, has shown certain benefits over the the chemotherapy that is given through the IVs, that is the intravenous. So this, to assess this particular role of HIPEC or not, initially when doing a diagnostic or a staging laparoscopy, we do assess the disease of the inside the peritoneal cavity and score it. And this particular score is, if it is less than 10, we usually consider these patients for a HIPEC depending upon their response to chemotherapy. Now, if there is no obstruction, as I told you, if there is no obstruction, we go ahead with neoadjuvant chemotherapy after doing a diagnostic or a staging laparoscopy, and then reassess for surgery. Now, as far as surgery is concerned, there are basically, we remove a part of the stomach or a full of the stomach, that is a partial gastrectomy or total gastrectomy. This basically depends upon the size of the tumor and the location of the tumor. If the tumor is situated very close to the cardia or the upper part of the stomach, or it is close to the fundus, then we do a upper radical gastrectomy. If it is situated lower down, we do a distal radical gastrectomy. Suppose the tumor is big, say about 5 centimeter and more. In such cases, we may have to do a total gastrectomy. So this is as far as the primary tumor is concerned. But as you know, the disease can spread from the primary tumor to the adjacent areas, what we call the lymph nodes, and also to the just adjacent structures like pancreas or otherwise. So these are the areas we have to look into during the surgery and decide as to the extent of the surgery that needs to be done. Now, when I do a total gastrectomy or a partial gastrectomy, I do a nodal clearance as well. And this nodal clearance gives a good survival benefit as far as most of these patients are concerned. Now, once I do a partial gastrectomy or a total gastrectomy, we need to bring the continuity back by bringing the intestine and joining it to the stomach. So there are different methods by which we do it. These are basically done to allow the food from the stomach to go down into the intestines directly. This surgical approaches to the cancer of the stomach can be varied. The most commonly done procedure is either the partial gastrectomy or a total gastrectomy. They can be done by open method, by doing a laparotomy, or it can be done by a robotic surgery. Now we have here in the Shankara Cancer Hospital and Research Center, we have a robotic unit where we do a gastrectomy also through this robotic procedure. The main advantage with robotic procedure is that it is less painful, small scars, less bleeding, and early recovery. These are the main advantages and is more of a precision surgery. So there is a lot of advantage with robotic surgery for gastric cancers as well. That you can edit a little